This is Handsome ASMR, back with another ASMR video. This time we are going to be talking about how to work up patients with shortness of breath. So let's begin. In general, diagnosing and working up patients with shortness of breath involves a thorough and systematic approach to determine what could be causing this. The workup should begin with an efficient history, physical exam, and appropriate set of diagnostic tests based on the clinical findings. So, regarding the initial assessment of the patient and history taking, we first want to gather a thorough history of present illness. So we should ask the patient about the onset of the shortness of breath, whether the onset was more acute or chronic in nature, because sudden onset suggests conditions like pulmonary embolism, asthma exacerbation, or acute heart failure, while chronic onset may indicate chronic obstructive pulmonary disease, or COPD, heart failure, or interstitial lung disease, or ILD. We also want to ask about duration, whether the shortness of breath is continuous or episodic. If it is episodic, ask about the specific triggers like exercise, cold air, or allergens. These are common triggers that can lead to shortness of breath. We also want to ask about severity. So, ask if the patient can complete normal activities regardless of the shortness of breath, or if they have significant limitations. So, some limitations can manifest into orthopnea, where the patient will have to sleep with multiple pillows in order to relieve the shortness of breath while sleeping, and then paroxysmal nocturnal dyspnea, where they experience shortness of breath at random times while asleep. We also should ask about associated symptoms, so ask the patient if they have any chest pain, cough, wheezing, sputum production, or mucus production, whether they are vomiting blood, whether they have fever, or if they have edema in their ankle area. Of course, we should then ask about the past medical history, so we should ask cardiac-related questions, whether they have history of heart failure, having ischemic heart disease, arrhythmias, or valvular heart disease. We should also ask about any pulmonary-related illnesses, whether they have been diagnosed with asthma, COPD, pulmonary fibrosis, whether they have previously had pneumonia, tuberculosis, or prior embolic events, like deep vein thrombosis. We should, of course, inquire into other comorbidities, like diabetes, renal failure, obesity, or malignancy. It's also important to inquire about the social history, so always ask the patient if they are currently smoking, or if they have smoked in the past, because smoking is a key risk factor for COPD, along with lung cancer and various cardiovascular disease. Occupational exposure should also be inquired into, whether the patient has been exposed to asbestos, because this is a major risk factor for lung cancer and mesothelioma. Whether they have been exposed to dust or various chemicals, because some chemicals can lead to the development of pneumoconiosis or co-workers' lungs. Also ask about travel history, because this is important for inquiring, or at least figuring out whether the patient could be afflicted with tuberculosis, pulmonary infections, or even pulmonary embolism, because prolonged travel is a major risk factor for deep vein thrombosis, and deep vein thrombosis can lead to pulmonary embolism if not treated immediately. And then ask about family history, so whether the patient's family members have had any cardiovascular or pulmonary diseases like heart failure, asthma, or hereditary conditions like alpha-1 antitrypsin deficiency. After you take the history and after you do the appropriate review systems, now it's time to do a physical exam. So always inspect the general appearance of the patient. Look for signs of respiratory distress, such as tachypnea or fast breathing, the use of accessory muscles to breathe, or whether there is nasal flaring obvious upon the patient. Furthermore, cyanosis or the skin turning blue or clubbing can point to chronic pulmonary disease or heart failure. Also, review the vitals. So review the respiratory rate and effort. So this is because tachypnea can suggest an acute exacerbation of a condition like asthma, congestive heart failure, or pulmonary embolism. Check the pulse oximetry because hypoxemia should prompt further investigation into causes like pneumonia, pulmonary embolism, or interstitial lung disease. And then blood pressure is important for evaluating hypertension or hypotension. This can lead to narrowing our differential to diagnoses that are more cardiovascular in nature. And then we need to do a chest physical exam. So we need to inspect the chest, check for any asymmetry, increased work of breathing, or signs of trauma. We also want to do a tactile fremitus and chest expansion test because diminished fremitus or decreased expansion may indicate a pleural effusion or pneumothorax. Finally, percussion is important because in case of pneumothorax, there can be hyperresonance or there can be dullness, which can indicate consolidation or effusion or pneumonia in some cases. And of course, listen to the lungs and heart sounds. When you listen to the lungs, if you hear wheezing, this could indicate bronchospasm, where this could be based on or the result of asthma, COPD, or an allergic reaction. If you hear crackles, this could indicate the presence of fluid in the lungs, and this can be due to heart failure, pneumonia, or interstitial lung disease. If you hear rubs, that can be a sign of pleural effusion or pericarditis. And then when you listen to the different fields for listening to the heart, always assess for any murmurs. If there is the S3 heart sound, that could indicate some form of heart failure. Or if there is an irregular heart rhythm, always check for any arrhythmias, as that can also lead to shortness of breath. So, when you take the appropriate history and physical, the next step is to narrow down your differential diagnosis. This is a tricky part for working up patients with shortness of breath because the differential for this particular chief complaint can be broad, as shown over here. So, some possible cardiac causes of shortness of breath include systolic or diastolic heart failure, acute coronary syndrome, arrhythmias like atrial fibrillation or AFib for short, pericardial disease like pericarditis or tamponade, and then valvular heart diseases like aortic stenosis or mitral regurgitation. There are many pulmonary causes like asthma or COPD exacerbation. There's also pulmonary embolism, pneumonia, or other respiratory infections, pneumothorax, interstitial lung disease like pulmonary fibrosis, ECG is important for arrhythmias, ischemic changes, or signs of heart failure. Chest X-ray is also mandatory at this point, so that you can rule out pneumonia, heart failure, pneumothorax, or large pleural effusions. There are some other laboratory tests to order, such as complete blood count to check for anemia or infection, B-type natriuretic peptide or BNP. This will be elevated in heart failure. And a D-dimer can also be ordered if pulmonary embolism is suspected, even though false positives can take place if the patient has some form of infection or if they are pregnant. Arterial blood gas, or ABG, is needed to evaluate the degree of hypoxia and acidosis. This can be useful in cases involving asthma exacerbation or acute respiratory distress syndrome. Troponins will be useful if acute coronary syndrome or myocardial infarction is suspected. And then procalcitonin is helpful in distinguishing bacterial infections from other causes of shortness of breath. And then we have imaging and advanced tests we could use. So, if a hospital has high-resolution CT scan, that is helpful because they can help to pinpoint whether interstitial lung disease, pulmonary embolism, or lung malignancy is suspected. You also want to consider ordering CT pulmonary angiogram if you suspect pulmonary embolism. And then echocardiography can be or is necessary to assess for heart failure, valvular disease, or pericardial effusion. And then spirometry can be useful for evaluating obstructive lung diseases like asthma and COPD. And then pulmonary function tests are useful if chronic lung diseases like COPD, restrictive lung disease, or any other related diseases are suspected. So after you have confirmed the diagnosis, you need to manage the underlying cause. If the cause is cardiac in nature, consider optimizing heart failure treatment, such as using diuretics, ACE inhibitors, or beta blockers. You might need to manage the arrhythmias and consider revascularization if acute coronary syndrome is diagnosed. If the cause of the shortness of breath is pulmonary in nature, treat the underlying conditions like asthma by using bronchodilators or steroids. You can use antibiotics to treat the pneumonia, anticoagulation for pulmonary embolism, or needle decompression or chest tube for cases of pneumothorax. And then, of course, provide supportive care through oxygen therapy if patient is experiencing hypoxemia, and then non-invasive ventilation, such as your continued pressure airway purifier or BiPAP for respiratory failure. Or it's a CPAP machine, I can't remember the acronym, but I'll get to that later or in the next video hopefully. And then monitor closely for worsening symptoms or complications, particularly in acute cases where rapid intervention may be needed. And then, once the acute issue is resolved, continue to manage the underlying chronic condition, especially if the patient has COPD or failure or asthma. And then, of course, educate the patients on lifestyle modifications, medication adherence, and symptom monitoring. And just in general, it's always appropriate to first manage acute conditions before focusing on chronic conditions, because in acute conditions usually yield more dire dire situations where the patient's life is more at risk. And so you want to manage that first. And then just keep in mind that the information I provided to you today is mostly a broad outline, and that every patient is different, and they'll play a huge role in determining how to manage their chief complaint and how to manage their underlying conditions. And so, here's a nice figure I found online. I think this does a good job of highlighting the different causes of the shortness of breath. That is it for today's ASMR-like video. Please like and subscribe if you want more videos like this, and I shall see